Dr. Reinhardt, Michael Reinhardt. I'm the director of the Brooklyn Initiative to Develop Geriatrics Education. Thank you all so much for your patience and for tuning in for this really important talk. The Brooklyn Initiative to Develop Geriatrics Education, or BRIDGE for short, is a program funded by the Health Resources and Services Administration as part of their Geriatrics Workforce Enhancement Program funding. And it's my pleasure to welcome you today for this really important session on delirium, an important clinical entity that dramatically affects clinical outcomes for our older patients globally, and in particular here in Brooklyn. This lecture is the first in a series of talks that will support the activities of the BRIDGE program, as well as our new advanced certificate program in public health geriatrics in the School of Public Health at SUNY Downstate Health Sciences University. Our BRIDGE program was developed in partnership between 4 of the colleges and schools at SUNY Downstate Health Sciences University, including the College of Medicine, College of Nursing, School of Public Health, and the School of Health Professions. This truly interprofessional partnership of our colleges and schools is complemented by our outstanding partners in the community, including New York City Health and Hospitals, Kings County, Brownsville Multi-Service Family Health Center, and the Fort Greene Council, and their network of 13 senior centers throughout the borough. The overall goal of the BRIDGE program is to provide the education and support needed for Brooklyn to become an age and dementia-friendly place for our senior neighbors to obtain their health care. It's our pleasure today to welcome Dr. Tammy T. Hshieh to speak on the important topic of delirium. Dr. Hshieh is an associate physician at Brigham and Women's Hospital and assistant professor in medicine at Harvard Medical School, Boston. After graduating from Harvard University with a bachelor's degree in biochemistry, she received her medical degree from Alpert Medical School of Brown University. Dr. Hshieh completed her residency in internal medicine at Beth Israel Deaconess Medical Center and the Harvard Fellowship in Geriatric Medicine. She received a master's in public health at the Harvard Chan School of Public Health. Dr. Hshieh is a physician scientist with a focused interest on improving cognition and function in older patients and promoting healthier aging. Her research is focused on delirium and cognitive impairment and preventing these common conditions with high morbidity and mortality among older adults. Clinically, Dr. Hshieh is an attending geriatrician in the inpatient consultative service at Brigham and Women's Hospital. She also leads the older adult hematologic malignancies clinic at Dana-Farber Cancer Institute, which focuses on improving the quality of care for older oncology patients. Her goal is to continue clinical research and investigation to help in the development of cutting-edge models of care that prevent and positively intervene on delirium and dementia and aging. So without further ado, it's my pleasure to turn the mic over to Dr. Hshieh. We'll be holding questions for the end of Dr. Hshieh's talk, and as a kind request, at the end of the talk, you'll be receiving an invitation from us to complete a survey on your experience so that we can guide our future programming to best serve the downstate and Brooklyn communities at large. Thank you, Dr. Hshieh. It's great to have you.
Thank you so much for that introduction. I'm really happy to be able to be here to talk about a topic that has been near and dear to my heart since medical school, actually. So I'm going to go ahead and share my screen. I want to talk to everyone today about delirium. I have no disclosures. The learning objectives today are to help us choose the best tool to screen for delirium, particularly in the outpatient setting, determine modifiable risk factors for preventing delirium in older adults, and help us develop a toolkit with strategies to manage or prevent delirium in the outpatient setting. I'm going to bring some questions to your attention, things to think about during this talk, and we will answer these questions hopefully by the end of this discussion. So question number 1, there are a number of methods to evaluate and assess performance status in geriatric patients, including the Charlson Comorbidity Index, the Karnofsky Performance Scale, and the Fried's Frailty Phenotype. What is one variable, however, that is not routinely assessed? It's A, ADLs and IADLs, smoking, tobacco, alcohol, and illicit drug use, unintentional weight loss, or cognition. Question 2, you are seeing an 86-year-old patient in clinic after a brief hospital stay for heart failure exacerbation. The patient was briefly in a SNF rehab and then returned home with services. The family expresses concerns about progressive cognitive decline, and in particular, they describe agitation and confusion in the last 2 days while at home. The patient is confused and delirious in the clinic. They're CAM positive and inattentive. Would you go ahead and proceed with cognitive testing and evaluation at this time? Yes or no? Question number 3, the incidence of delirium in older patients in the hospital ranges from 11 to 51%. Which of the following interventions is evidence-based, proven by studies to be effective in preventing delirium, especially in-hospital delirium? Is it A, administration of antipsychotics or atypical antipsychotics? B, multi-component non-pharmacologic interventions? C, restraints and bed and chair alarms? Or D, personal care analgesia pumps for patient-driven pain control? So what exactly is delirium? The definition for delirium is an acute disorder of attention and cognition with high morbidity and mortality. There's generally considered 2 subtypes, the hypoactive, where patients are somnolent, and a hyperactive, where patients are agitated. For delirium screening, the first step to preventing and treating delirium is really screening and awareness of the condition and the problem. We know that back in 2000, 2001, the rates of unrecognized delirium ranged from 55 to 70%. Unfortunately, in 2015, the rates were still upwards of 60% of unrecognized delirium. We also need to remember that delirium happens in the outpatient setting too, with an incidence predicted at 2 to 22%. The best way probably to think of delirium initially is to try this mnemonic, IATA. A for acute and fluctuating, I for inattention, either unable to do days of the week backwards or months of the year backwards. D, disorganized thinking, incoherent or rambling. And A, altered level of consciousness, whether drowsy, lethargic, stuporous, or hyper alert and agitated. And why do we care? We have a picture here of the silver tsunami, which is how geriatric patients have been described in recent literature. There are more and more patients who are geriatric and elderly, and so there are more and more patients who may become delirious, both on the inpatient and the outpatient side. But also delirium is costly, up to $33 billion per year for just postoperative delirium, or that translates to $44,300 per patient per year. In addition, severe delirium results in an additional $56,000 per patient per year. And that means that post-op delirium alone rivals the costs per year for the United States as cardiovascular disease and diabetes. And we also know that delirium results in poor clinical outcomes. Patients with severe delirium tend to have prolonged lengths of stay in the hospital, increased discharge to post-acute nursing facilities. And we also know now that severe delirium in patients in the hospital result in significant decline in ADLs, and they often end up staying in nursing homes for over a month and beyond. And we know now that delirium isn't something that just happens and you snap out of it, whether you're in the hospital or you get to go home. Delirium has serious complications, and these result in increased length of stay in the hospital, increased healthcare costs like we just touched upon, increased risk of falls, functional and cognitive decline, institutionalization, mortality, and then also some things that we don't think about as often are PTSD and caregiver burden. And here we see from a previous study that there's significant morbidity and mortality to delirium regardless of the population. In particular, I want you to look at the fact that patients in nursing homes and post-acute care, if they're delirious, the prevalence and incidence is pretty high, 14%, 20 to 22%, and there is an increased risk for mortality for these patients. Delirium is often unrecognized, and yet we have quite a few instruments to screen and to detect delirium, including the confusion assessment method from the 90s, the CAM ICU, the 3-minute diagnostic interview for CAM severity, and also the 4AT, which was developed in Europe and has factored in more of the patients with dementia, and then a number of other delirium screening tools as well. So I want to bring to your attention the UB-CAM, which is the 2-item ultra brief delirium screen. There's a nice easy guide that you can pull offline to use. And this is something that can easily be done on the outpatient setting as well as inpatient if you're particularly busy. And you can see it's very user-friendly. You basically ask 2 questions. And if they're incorrect on either question, we recommend that you proceed with either the full CAM or 3D CAM to kind of get more information about the person's mental status at that time. And as you see here, I bring up the CAM-S short form. This is a nice screening tool that's also very nuanced in the fact that you can also look at severity of delirium, but it's also pretty easy and pretty user-friendly. And this is also widely available online. You just need to look for it. It's available on the help website, NIDIS. It's pretty easily accessible. And I want to show the delirium screening tool for outpatients that can be used by family as well, also known as the FAM-CAM. Here's the worksheet that you would use as a family member to determine whether your loved one is potentially delirious. And often we find that, or we hear from families that it's very empowering to be able to do their own assessments because they know their loved ones very well, to be able to help the medical providers be able to determine whether someone who's waxing and waning may actually be delirious. So now I want to talk a little bit more about delirium prevention, which is probably the best thing we have, the best tool that we have right now in the literature and clinically to help manage, prevent, treat delirium. So we know by now through a lot of different studies, the risk factors for delirium. Here we see here on this chart, the things that predispose patients to develop delirium, whether in the hospital or on the outpatient setting. You see that dementia is important to have pre-existing dementia, functional impairment, visual impairment, hearing impairment, also very important. Depression greatly increases your risk for developing delirium. And then psychoactive drugs or just drugs that patients take on a regular basis. So we'll talk a little bit more about this during the rest of this talk. So first thing, cognitive impairment or pre-existing dementia. Delirium versus dementia is a very classic thing that we ask med students about, we ask residents about. What is the difference between delirium and dementia? This table kind of describes the differences in a nice organized way. You see here that delirium is typically abrupt and can last hours to days, whereas dementia is usually insidious and progressive, takes months to years to happen. And delirium is usually, the hallmark of delirium is inattention, the reduced ability to sustain or shift their attention, whereas attention in dementia is actually intact. It should be normal unless they're severely demented with quite a few other hallmarks of dementia. Their consciousness fluctuates and they often have a reduced level of consciousness in delirium, and consciousness is intact in dementia. For delirious patients, their speech can often be incoherent, tangential, disorganized. Dementia patients often maintain their social graces and their speech. Their speech is often ordered. They often ask you how your day is going. They are usually more eloquent than someone who's delirious. Other features of delirium include hyperactive, hypoactive forms, sleep-wake and perceptual disturbances, and these tend not to occur in dementia, although it may vary by different kinds of subtypes. So the challenge is that delirium and dementia often coexist clinically. Dementia is the leading risk factor for delirium, and delirium increases the risk for developing dementia. So we know that pathophysiologically, there's a lot of overlap with shared mechanisms between delirium and dementia. And that's why we hope that broader understanding of delirium will allow us to better understand dementia as well. So I bring this study to your attention because although this was done in a population of older patients with hematologic cancers, what we often don't realize on the outpatient setting is just how prevalent cognitive impairment is. This was done at the Dana-Farber Cancer Institute, where we did the clock in the box and the MoCA delayed recall questions on patients as they came in for initial consultations with oncologists. And we saw that 127 of the patients that were studied or were part of the study, or 35% of them, had probable executive dysfunction. And 62 of these patients, or 17% of them, had probable impairment in working memory when we asked them the 5-word delayed recall. What we did find out was that these patients with impaired working memory had a worse median survival, and this was even after we had stratified by cancer aggressiveness and other covariables. So this shows that cognitive impairment, both in executive dysfunction and working memory, is highly prevalent in the general population and has implications on people's survival. We found that impaired working memory was also associated with worse survival for those who were undergoing intensive treatment, and executive dysfunction was associated with worse survival among patients who underwent intensive treatment. And so this kind of reminds us that regardless of any patients that come in to see you in clinic, you might want to consider a quick 5, not even 10-minute cognitive assessment to try to meet the patients where they're at and to help them work through their cognitive impairment. When you find a patient with cognitive impairment, it doesn't mean that you're not going to treat these patients. It means that you work with them on whatever their dysfunction is. So someone with executive dysfunction, you might want to work with them to break down multi-step instructions into very clear finite instructions. People with impaired working memory, you might want to work with them on writing things down and being very explicit, talking to family members and making sure that everyone gets the information so that their treatment plan is clear. So how do you approach cognitive impairment? I just touched on this a bit, that it's relatively easy to do. First of all, to get collateral information from offspring, family members, primary care doctors, primary oncologists, social workers, anyone on their treatment team that might know the patient longitudinally. And then in terms of testing, the mini cog and the clock in the box are both really quick tests that take almost less than 5 minutes to do. And if they screen in for this, you might consider taking them back, bringing them back to the office for the full Montreal cognitive assessment. The MoCA we do like using in the outpatient clinic because it's very good at detecting executive dysfunction, including in mild cognitive impairment. It's less education based. You do have to remember that you can't test the patient if they're actively delirious. It's kind of not fair to them to do that. And the testing may be limited if the patient is very depressed and their depression has not been adequately treated. So like I mentioned earlier, what are the interventions for someone that you find with cognitive impairment? You don't withhold care. You don't withhold, whatever treatments you might want to consider for them. You think about things like writing all instructions down, following up with phone calls, even if they end up in the hospital, correcting sensory deficits like vision and hearing impairment, planning and working very hard on dispo planning with the family in terms of setting up physical therapy, visiting nurses, home health aides, and thinking about cognitive rehabilitation options. There is an online/app called Posit Science or Brain HQ, which was developed by neuropsychologists as well as neurologists. So for some of your more tech savvy patients, you can try that. It was also quite useful to use that as a bridge for patients during COVID. And then considering some kind of formal cognitive rehabilitation. In Boston, we have Spalding and GH. They both have options for cognitive rehabilitation. And then thinking about reversible causes like medications. Are these patients on benzos? Are they taking Zyprexa for nausea or behavioral issues? And then trying to make sure that patients are not getting too much Benadryl or steroids, depending on why they're getting treated with those medications. I want to talk a little bit about functional and vision impairments in and of themselves, because these sensory neural deficits can also precipitate delirium in patients, both on the inpatient and the outpatient side. I'm huge advocate of physical therapy, either by visiting nurses or outpatient, making sure that patients have adequate assist devices at home. If patients have 2 floors, it doesn't hurt to suggest to them that they have multiple assist devices at home so that if they have cognitive impairment or just are lazy one day, they don't just forget to use their cane and end up falling because it's not readily accessible. And then ensuring adequate vision. Cataract surgery in a timely manner if it's indicated, macular degeneration, getting injections or the AREDS medications, and glaucoma management. For hearing impairment, hearing aids can be a little bit tricky, as probably a lot of outpatient providers understand. Sometimes they can only get one per lifetime. They often get these lost. So I've often recommended a hearing amplifier in the meantime while we're trying to get them their hearing aids, and then making sure that there isn't cerumen impaction affecting their hearing. And then depression in the elderly. We know that depression increases the risk for delirium. It also kind of changes the patient's perception of pain. So you want to make sure that depression is adequately treated. And it can present as pseudodementia, a term that I'm not a fan of using, but it's important to remember that patients who have untreated or inadequately treated depression often will manifest memory loss. I like citalopram and escitalopram as medications to start with for patients with depression who are elderly. I tend to avoid paroxetine and venlafaxine. And the main reasons is because although those two medications are great for anxiety, there is the risk for withdrawal. Patients tend at older ages to stop and start medications on their own. And so if you stop paroxetine and venlafaxine randomly, you can risk going into withdrawal. So I usually opt for citalopram or escitalopram instead. And then there's the risk of polypharmacy. We know that polypharmacy increases people's risk for delirium. It increases the risk of interactions with chemotherapy, with NOACs, and bleeding risk. And it's important to want to develop a collaborative relationship with families and patients. You want to pick your battles. So I often try to be open about all supplemental alternative medications patients might be taking and have a very frank and open conversation with the patients and their families, because that often opens a whole new can of worms when they're comfortable in telling you about all these other medications that they're taking over the counter and all the supplements that they might be taking, or all the Benadryl that they're buying over the counter as Advil PM to help them sleep. We know that polypharmacy is related to frailty in older adults, and so that's why this is important. And then I refer here to the Memorial Sloan Kettering website. They have a integrative medicine website that's quite nice with a lot of evidence-based medicine there that's available for patients and for healthcare providers that you can review if you come across a medication that you're not familiar with. And there's also been developed quite a few nice polypharmacy scales that you can refer to. For example, the anticholinergic risk scale, which was developed by by Jim Rudolph a couple years back. And you see that it's very user-friendly with point scale that you can add up and see just how high risk a patient is in terms of anticholinergics on their problem and medication list. And then Malaz Bustani developed another anticholinergic burden scale that we'll see on this slide, which is also very easy to use to see if a patient's medication list puts them at high risk for developing delirium and other complications of polypharmacy. Now, I want to just speak very briefly about frailty because we do know that delirium and frailty are often intertwined. Patients with delirium become more frail. Patients who have frailty are at higher risk of delirium. Frailty is most often defined as an aging-related syndrome of physiological decline characterized by a marked vulnerability to adverse health outcomes. Frail older adults tend to present with an increased burden of symptoms like weakness, fatigue, medical complexity. They often can't tolerate medical and surgical interventions in the same way that a patient may be the same age, but at a lower level of frailty can tolerate. And so I often talk to patients about functional and cognitive cognitive reserve, because that's what we're thinking about when we're talking about delirium. How much functional and cognitive reserve do you have, and how high risk are you of tipping over the edge when you push a little bit? And this is a nice study from Hubbard et al. From 2017, where they looked at frailty and delirium. And you see how for inpatients in the hospitals throughout Australia, with every increase of zero point 0.1 on their frailty index that they calculated for their patients, their odds ratio of developing inpatient delirium was 2.34. So you see how frailty and delirium are very closely intertwined. And then I just want to remind everyone about the social determinants of health for older adults. There's quite a few things that impact an older adult's health. And you just want to remember that when you see a patient and you think about just how high risk are they for delirium? How can I prevent delirium in this patient? I'm seeing them in clinic right now, but what are their chances of developing delirium if they were to get a pneumonia, end up in the hospital? These are all the things that play a role in older adult care. And so I like to say that the plan is key. This is what geriatricians and age-friendly clinicians do best. We see patients, we determine their risk factors, and then we develop a plan. We either introduce and suggest interventions, we connect them with resources and supports, and we develop a longitudinal relationship with these patients that help them as they age and as they run into complications like delirium in the hospital. So here I want to show you delirium prevention. This is the American Geriatric Society clinical practice guidelines for postoperative delirium, but they really do apply to all patients in the hospital and potentially outpatient as well, in terms of the most evidence-based medicine that we have at this point in preventing and treating delirium. And so we do know that the strong recommendation from HES, as well as from the American College of Surgeons, is for multi-component non-pharmacologic interventions, keeping people mobile in the hospital, walking around, avoiding restraints, avoiding medications that are psychoactive and toxic to older adults, constantly orienting them to their surroundings, making sure they have adequate oxygen, fluid, and nutrition. But we also know that other things that are low tech but high touch are also very important, such as educating your healthcare providers in the hospital, educating family about the importance of managing risk factors for delirium, constantly evaluating their medical condition, their pain management, and reviewing their medication list regularly to make sure that you're avoiding medications that put patients at high risk for delirium. And so this is just a nice list that breaks down the multi-component non-pharmacologic delirium interventions. These can work as outpatient as well, in particular, bowel regimen, sleep aids, mirtazapine. I'm not really above using medications to try to maintain a healthy sleep-wake cycle in patients, because as all of us are probably aware, having insomnia, not being able to sleep at night, and then having to deal with the whole day ahead of you is pretty stressful and discombobulating even for us when we're young. And so I often recommend having very good sleep hygiene and bowel regimen, and making sure that all of these low-tech issues are addressed is very important in keeping our older patients from developing delirium. So we did a meta-analysis a few years ago where we looked at 11 studies to see how they were able to use multi-component non-pharmacologic interventions to reduce the incidence of delirium. And we were able to see that it definitely worked to use even just two non-pharmacologic interventions seemed to significantly reduce the incidence of delirium in the hospital. And the interesting thing too was that the rate of falls decreased significantly as well among intervention patients in 4 studies, just by doing these multi-component non-pharmacologic delirium interventions. This was the first meta-analysis or study of its kind that demonstrated that these interventions can actually decrease the rate of falls. Now, I want to talk briefly about antipsychotics for prevention and treatment because there's been multiple studies looking at medications to see if we can use them to either prevent or treat delirium. And unfortunately, the current evidence doesn't support the use of Haldol or second generation antipsychotics for prevention or treatment of delirium. They've studied Haldol in particular, as well as the atypical antipsychotics, and it really did not improve any outcomes, specifically length of stay, cognitive function, delirium severity, or caregiver burden. And there's also limited evidence that second generation antipsychotics can do much for delirium incidence in specifically postoperative patients. And so right now, the teaching is really that we should avoid medications for preventing and treating delirium. Really, it's an ounce of prevention that is the most important and the most useful. I put down here trazodone. Anecdotally, at our hospital, we have found for inpatients trazodone to try to help maintain sleep-wake cycle and to help with a touch of anxiety while in-house tends to be helpful as well. And then Seroquel is our go-to at our institution. I know other institutions may vary, but it seems to be a good one that's very titratable and avoids tardive dyskinesia and Parkinsonian patients. Zyprexa is useful because it has an anti-nausea component as well, but it does have a long half-life. And so with any of these medications, even though the evidence does not support using them to prevent and treat delirium, if you really have to use it, you can use them at low doses and you time them appropriately. You can potentially make a difference and make a dent in the delirium that the patients are experiencing in-house. And so here is a nice schematic from Esther O's JAMA review on delirium management. It's useful to have, to look at, to see some doses for the antipsychotics, and to remind yourself of the things that you need to be aware of when you're treating someone with delirium. So now we have some questions for the group. I think we're going to try to do a poll with this. So this was the first question I introduced earlier. There are a number of methods to evaluate and assess performance status in geriatric patients. These include the Charlson Comorbidity Index, the Karnofsky Performance Scale, and Fried's Frailty Phenotype. What is one variable, however, that is not routinely assessed? Is it ADLs and IADLs? Is it smoking tobacco, alcohol, and illicit drugs? Is it unintentional weight loss? And is it cognition? Okay, we'll give everyone a moment.
Just give everybody another minute or so. Dr. Hshieh, both questions were open, by the way, just so you know.
Maybe I should read the second question also. Yeah. So
Whatever is your preference, just letting you know.
The second question is, the incidence of delirium in older patients in the hospital ranges from 11 to 51%. Which of the following interventions is evidence-based, proven in studies to be effective in preventing delirium, especially in-hospital delirium? Is it administration of antipsychotics or atypical antipsychotics? Is it multi-component non-pharmacologic interventions? Is it restraints like arms, legs, mitts, and bed and chair alarms? Or is it a PCA pump for patient-driven pain control? give the group a couple more minutes.
You should be able to see the results now, yes?
Yep, okay. My question. Excellent, all right. So I think there's a little bit of variability on the first question. Should I stop share on this?
Sure.
Okay. So for question 1, the right answer is actually D, which cognition is not routinely assessed in older patients, including those potentially undergoing surgery or initiating oncology treatment. These are the two populations of patients I tend to take care of here at the Brigham and Dana-Farber. Other variables that are important for older patients but are not routinely assessed include vulnerability and mood and depression. So arguably there's a higher prevalence of cognitive impairment among older patients than recognized, and these have implications for important outcomes like delirium, functional debility, nursing home stay, etc. And that's why I'm kind of putting a plug in right now for people to assess cognition. I definitely understand it's important to ask about tobacco, alcohol, and drugs, particularly alcohol, because I've been finding that we sometimes write off patients as, the little old lady who never drink alcohol, but they actually have a stash of wine in their house, or their assisted livings regularly serve wine at dinner. And so I definitely understand the importance of that. It's kind of related to cognition as well, right? With alcohol consumption or excess alcohol consumption. So I definitely see the importance of that. But I do want to put a plug in for people to assess for cognition. And if there's something wrong with cognition, to think about what might be causing it. Is it alcohol? Is it depression? Is it, something else going on? But I think too often we kind of forget about that, and we forget about the fact that our patients tend to get dressed up and come in well supported, looking their best when they get to see their doctors or their healthcare providers, their nurse practitioners, etc. And so we think that they're doing fine when they actually have significant underlying cognitive impairment, and it was an extremely heavy lift for their families to bring them in that day. Okay. And this was the second question. Or let me go first to the third question, because that was in the poll about the prevalence of delirium. And you guys all got this one right, that the answer is multi-component non-pharmacologic interventions. So the American College of Surgeons and the American Geriatric Societies have joined together to recommend guidelines centered around multi-component non-pharmacologic interventions to decrease the incidence of delirium. And this is driven in part by the growing evidence that post-operative delirium in particular is associated with significant morbidity and mortality. It's no longer considered this transient acute condition that you can snap out of. And so this likely applies to delirium in general as well. So we recommend examining pharmacologic prevention and management of delirium a little bit more to see if there's any potential benefit to these medications. Our colleagues, our surgeons tend to think, the surgery went great. So we want to try to help them with their success and make sure that patients don't develop delirium or severe delirium after surgery, and give them the best shot at recovering from, let's say, a fall with a hip fracture. So you guys did excellent on that question. And then the last question that we had earlier, I think it was just too wordy to fit into the poll, but it's a clinical question. You are seeing an 86-year-old patient in clinic after a hospital stay for heart failure. They were briefly in rehab and did well and went home, but the family has noticed a progressive cognitive decline. They're worried about it. And they actually mentioned that in the last 2 days, the patient's been acutely agitated and confused. And now that the patient is sitting in front of you in clinic, they're CAM positive, inattentive. Would you go ahead and proceed with cognitive testing like the family recommended? Is the answer yes, because the family's concerned, you've known the patient for a long time and you're kind of curious yourself? Or no, cognitive assessments cannot be done while the patient is delirious? So the answer to this question is no. Cognitive assessments cannot be done while the patient is delirious. It's kind of like trying to test someone who's under the influence. Patients with active delirium should not undergo cognitive testing until delirium has resolved. Otherwise, the results would be inaccurate. And similarly, significant untreated depression, reversible organic disorders like severe hypothyroidism, vitamin deficiencies, neurosyphilis, seizure disorders, all of these things should be medically treated before a patient undergoes cognitive testing for potential diagnosis of dementia. So just some take-home points for everyone to consider. Delirium screening, prevention, and management are feasible even with limited resources. APPs can do it, MDs, DOs, social workers, infusion nurses, anyone on the multidisciplinary team can help. Identifying and managing risk factors for delirium prevents the complications from happening. Delirium management improves the quality of life and the quality of care. It's cost effective and improves quantity of life also. And geriatrics takes a multidisciplinary, collaborative approach to patients. I like to describe it as taking the journey with them. Thanks. Are there any questions?